Good afternoon. Thank you very much for the invitation. I appreciate the opportunity to present here today. My name is Timothy Waitkus. I'm the Director of Marketing for the respiratory portfolio for Olympus, includes our bronchoscope portfolio, both reusable and single use, as well as our endobronchial valve portfolio. So that's kind of where we'll be focusing a little bit today. Unfortunately, the opportunity to present came to us at least a little bit late. Otherwise, I would have had one of our physicians with experience with this product join this presentation, but you're stuck with me instead. So first, a disclaimer. There are some quotes in here from two of our physicians, Dr. Bobby Tullis and Dr. Kyle Hogarth. They are paid consultants of Olympus. And any information that they're conveying is their based on their experiences and professional opinion. We'll give you a moment to quickly read through the rest of that disclaimer, and then we do have also a fair balance statement. I'm not going to talk extensively about endobronchial valves, but I will mention them. And so obviously, along with all the good that can come from the treatment, there are the potentials for complications, including pneumothorax, worsening of COPD symptoms, pneumonia, dyspnea, and in rare cases, death. So the full information is available on our website. And without that out of the way, I'll get into the presentation. So as all of you likely know, COPD is a leading cause of morbidity and mortality globally. And of course, that's just as true in the United States as it is the rest of the world. And when it comes to treatment options, there's really a long list of possible interventions from pharmacological therapy, such as bronchodilators, to oxygen therapy, to, as you can see on that screen, endobronchial valves for patients that are more advanced in their disease. And drilling in on endobronchial valves, you may or may not be familiar with the spiration valve system. This has been available in the United States for a number of years. It has an well-established track record of safety and efficacy, including a 9.5 point reduction in the SGRQ score. And the reality is that finding patients that meet criteria for valve therapy is a bit of a process. It starts with patients coming into the treating pulmonologist's office, either from clinic or as a referral, and progresses through a clinical workup, which includes things like PFTs, ABGs, 6-minute walk test, and many other advanced tests. And typically this workup process culminates with a radiographic assessment where they're assessing the patient's lungs for sufficient fissures. So one of the areas where lung volume reduction procedures can go wrong is if you have collateral ventilation from one lobe to the ipsilateral lobe. So one of the first screening criteria is we look to see how complete are the fissures in between the diseased lobe and the ipsilateral lobe. And that's typically, the last step of the process, that radiographic assessment. But as has been alluded to in some of the other presentations earlier, which I appreciated listening to, up to 70% of COPD patients are un or underdiagnosed. And so that means that they might not ever really find themselves in a proper treatment cycle and on a pathway to potentially benefiting from something like an endobronchial valve. And then of those patients that are diagnosed, roughly 82% of them are being treated by a primary care physician or a non-procedural pulmonologist. So you kind of think of it as like, of all the patients that are available, it's kind of like peeking through the blinds on your window. You only really have visibility to a small number of those potential patients. And then for those patients that finally do get to the treating pulmonologist, we know that as evidence from our IMPROVE study, which is our foundational clinical study, just 1 in 4 patients who enter a workup for BLVR will ultimately qualify for valve treatment. So that means that 3 out of 4 patients will disqualify at some step in the workup process, leaving those patients, a lot of patients, disappointed. And so here's just, again, breaking out our IMPROVE data. of those 75% of patients who disqualify, here are the reasons why they typically disqualify. Either they have PFTs that are not bad enough based on the ABG test, the medical history and comorbidities, exercise capacity. But as you can see, the main reason that they disqualify is that radiographic assessment. So 51% of patients, just based on their CT, are going to have fissures that are not sufficiently intact to make them a likely responder to therapy. And so they get disqualified. And typically that's the last step of the workup process. It's kind of the last thing that they do. So here's a quote from Dr. Bobby Tullis in Gulfport, Mississippi. He was one of our pilot accounts for this AI screening platform, but here's a quote that maybe might resonate with some of you. Establishing a consistent patient pipeline for BLVR, so that's bronchoscopic lung volume reduction, centers poses a real challenge. It demands substantial resources, such as community outreach, PCP education, and various factors that require a significant investment of my time as a treating pulmonologist. Balancing those demands while ensuring the highest quality of care remains a constant uphill battle. And so really feedback like that is why pulmonologists came to Olympus and said they really needed a more effective and efficient way to identify and qualify potential patients. And so with that feedback, our AI platform called Select Screening was developed. So Select Screening leverages artificial intelligence to operate silently in the background of your hospital's IT and radiology infrastructure to analyze any and all non-contrast chest CT scans that are performed in your institution for incidental findings of emphysema, regardless what the original order was for the CT. So once a potential patient is identified, their CT images are seamlessly sent to 4D Medical, who is our partner in this project, where they do a full QCT analysis to assess emphysema destruction and also look to see if they have those fissures that are sufficiently intact. Select reports, which is a report that kind of is the output of all this information, are then generated for all patients who qualify based on their CT for BLVR and are provided to the treating physician in a secure online portal for further workup or outreach. So not only are we lifting the shade to give greater visibility to those patients who may benefit from BLVR, we're also taking the clinical workup funnel and we're moving the number one reason for disqualification from the last step of the workup to the start of the workup process. So that reduces all that resource-intensive clinical testing on patients who ultimately are not going to qualify anyway. And so here's a quote from Dr. Kyle Hogarth. He said, since implementing Select Screening at his facility, the process of identifying patients for BLVR treatment has been completely transformed. Previously, it was a time-consuming task, but now patients are identified and pre-qualified before I even meet them for the first time. This has brought immense relief to both me and my team. Select Screening through 4D Medical enables us to efficiently follow up with patients who may qualify for treatment. It's truly remarkable how this advancement has streamlined our workflow and improved patient care. On the left-hand side, you see Dr. Bobby Tullis. This is a 90-day pilot. So over the course of 90 days, he analyzed 871 non-contrast chest CT scans, found 113 patients with severe enough emphysema to warrant further analysis. Of those 113 patients, 74 had a qualifying lobe based on fissure completeness, and 28 of those patients ultimately received valves. On the right-hand side, this is a full year's worth of data at the University of Chicago with Dr. Hogarth. They analyzed just shy of 7,000 CT scans, about 657 met selection criteria, and that we see that consistently. About 10% of patients in acute care hospitals in the United States are going to have clinically significant emphysema to warrant BLVR investigation. And in this case, 345 lobes qualified, and that's another consistent, about half of all patients are going to have fissures that are sufficiently intact for treatment. And over the course of that year, he was able to treat 88 patients with endobronchial valves through this screening program.